Hey everybody, welcome back to This Week in Global Health, otherwise known as TWiGH, which is a regular video series discussing relevant and current topics in global health. This episode, we are continuing our series featuring leading topics coming out of the latest publications from the Disease Control Priorities Network, which engages hundreds of health experts to assess effectiveness, cost, and cost-effectiveness evidence for global health interventions in different disease areas. Today, we're going to focus on cardiovascular, respiratory, and other related diseases, which we will talk about as Cvrd. And this topic is featured in its own volume and can be found at DCP3.org. I'm Jessica Taff, and I'm hosting this show today from the Washington, D.C. metro area. With me to discuss today's topic, I have two experts on this issue.
Hi, I'm Shuchi, Anand. I'm one of the volume's editors. I'm a kidney doctor based at Stanford University, and my research focus is on providing care for patients with kidney disease who live in low-resource settings.
Hi, I'm Nisreen Salti. I'm an associate professor of economics at the American University of Beirut in Lebanon. My research is in development economics, and I focus especially on the issue of inequities and inequalities in health and income.
Now, this volume covers 3 of the 4 major non-communicable diseases, NCDs, that have been prioritized by the UN High-Level Meeting on Health in 2011, namely cardiovascular diseases, respiratory diseases, and diabetes. Kidney diseases is also covered as a related condition as they share risk factors and can be prevented and controlled similarly as those other conditions. All of these diseases cause significant morbidity and mortality around the world, and they get a lot of attention in high-income countries. How does this differ in low and middle-income countries? What's the burden of disease like there, and why is there an increasing focus on addressing these diseases in low and middle-income countries?
So there are 2 points to make here. The first is that the burden of Cvrd is highest in low and middle-income countries. About 80% of all Cvrd deaths occur in low and middle income countries, and 40% of these are labeled premature deaths, meaning that they occur in people who are under the age of 70. The second is that the gap in prevention and treatment between high-income countries and low and middle-income countries is very high, and it's growing. Over the past decade, we've clearly made advances in caring for people with heart attacks or strokes or even kidney diseases, but high-income countries, while they've seen a decline in their age-standardized mortality by about a third for cardiovascular disease in particular, the rates in low middle-income countries are essentially stable to only 5% lower.
Right. And a key and concerning point that I read in this volume is the fact that actually living in a low and middle income country is actually a risk factor for death or a serious complication in any individual with a Cvrd, much in the same way that other risk factors like being overweight or having hypertension are. Why is that?
Yeah, I mean, that's so striking, right? And that point goes back to the second point we just made, in that persons who live in low and middle income countries, especially people who live in rural areas, experience really high risk for premature death or hospitalization related to Cvrd. And the advances that we've made in preventing or treating Cvrd have just not been made available to these residents.
And the consequences of having a Cvrd if you live in a low and middle income country goes beyond just this increased risk of death or serious complications. There's also a risk of debilitating healthcare costs to manage these conditions. Nisreen, could you explain why this is? Is it unavoidable?
So in most low middle income countries, the vast majority of people do not have health insurance coverage and have to pay out of pocket for healthcare. That means that people with cardiovascular respiratory disease in low middle income countries have to bear the cost of treatment and medication, and these can often push households into poverty. When more than 10% of a household's budget is spent on health, health spending becomes what analysts describe as catastrophic. or impoverishing. Is this unavoidable? No, and in fact, some of the packages proposed in the volume help get people out of, and lower middle income countries out of the situation where financial risk of healthcare costs is a burden.
It seems that in low and middle income countries, there haven't been the same benefits from the advances that have happened in prevention and care in high income countries. The volume notes that one of the main reasons is due to a lack of population-wide strategies to address behavioral risk factors like smoking or poor diet, physical inactivity. What are some examples of strategies that could be used in these contexts and the challenges that are associated with implementing them?
Right. I mean, as the volume and the key messages chapter highlights, prevention is probably, or activities around prevention is probably one of the most value for money interventions that low and middle income countries could take on. But some of the activities that we see, for example, in our workplaces in high-income countries where there's incentivization of physical activity, or we see our cities are being redesigned to incorporate more pedestrian plaza to encourage physical activity and public transport use, those kinds of high visibility changes in lifestyle or encouragement of changes in lifestyle are not as prominent in low and middle income countries.
So tobacco control strategies are one of the prime examples, given we have a lot of evidence showing that a comprehensive strategy in tobacco control is much more effective than any of its components alone. So taxation of tobacco becomes more effective when it's combined with a campaign for raising awareness on the health effects of smoking, with pictorial warnings on packets, plain packaging, bans on smoking in public areas, cessation programs. Often, opponents of tobacco taxes will say that they end up costing the government tax revenue because of reduced consumption of tobacco products, and also that they may have a larger financial burden on the poor. However, some of the research described in this volume of DCP3 shows that when all financial and health savings of reduced smoking are taken into account, the financial incidence of a tobacco control package may be progressive. This means that on the whole, more benefits accrue to the poor than to the rich. Now, for the challenges associated with implementation, particularly in low middle income countries, a lot of them have to do with difficulties in enforcement. So whether it's smoking bans or sales restrictions, but also with resistance often resulting from pressure and campaigning from tobacco multinationals. And so these are some of the main challenges for this very cost-effective intervention, which is tobacco control.
Now, treating CVRDs in their early stages or during an acute event like a heart attack or stroke, that can prevent serious complications later and save lives. However, these control strategies are being underutilized in low and middle income countries. For instance, 49% of people with hypertension in high income countries were aware of it compared to 31% in low income countries. And then you have 49% of people with hypertension in high income countries. You have 49% of people with hypertension in high income countries that were being treated for it versus 32% in low income countries. So there's this significant disparity between high income countries and low income countries with regard to these conditions. So why is this? What makes it challenging to treat CVRDs in their early stages in many of these low and middle income country contexts?
Yeah, so after prevention, probably the next step for tackling CVRD, that is, again, best value for money after prevention, is likely to be catching and treating CVRD in their early stages. But there again, we find that low and middle income countries have several reasons, but many reasons to not be able to first diagnose and screen people with these conditions in the early stages, which are these conditions are generally asymptomatic, and that's because there really isn't a primary care system that can serve as a catchment for the large populations that we're talking about. And then a second reason that we talk about in this volume is the lack of a uniform approach or regional guidelines that are sort of context specific. For example, in the setting of an acute event like a heart attack, there haven't been, as of yet, many protocols to guide a rural health clinic as to what to do. And, as a clinician, we could say, well, at the very least, they could provide aspirin and timely transfer of care. And both of these things could be time-saving. But the problem is that these health clinics have not been empowered to do so, so they don't know exactly how to step in. And in fact, there was recent research that came out of India from the state of Tamil Nadu that showed that something called a hub and spoke model, where peripheral hospitals are linked to major centers in the cities, can actually improve access to care during an acute heart attack. So by tripling the number of people who get to timely care. So clearly there is a way to develop region-specific protocols or guidelines that can make care in acute settings much more efficient. And then we also discuss in the volume the use of non-generic formulations of insulin for diabetes. And this is something that we use the example of countries from Latin America, where we found that many countries are using the more expensive non-generic formulations of insulin probably simply as a result of provider preference rather than any conscious strategy. Now, there's another way that low and middle income countries could make care more effective and therefore more available to a larger swath of people is by simplifying the availability, the options available to people for use of expensive therapies.
So Shuchi, I mean, yeah, like you say that right after prevention, getting treatment in the early stages is really important. And these missed opportunities to treat CVRDs in their early stages is a problem, because then it leads to advanced conditions, complications later. And this will require specialists and specialized facilities. And, in the LMICs, what are the challenges with providing advanced CVRD care, especially since it's probably, if we're missing the opportunity in the early stages, that we're going to have to address that later?
Right. And I mean, this is an important question. I think that even if we had the best case scenario where the maximal prevention strategies were implemented, then we had optimal early prevention. As clinicians, we know that it's unavoidable that people will develop advanced conditions, whether that's because of the pathogenesis of their disease or whether it's behavioral and or because they have a unique condition that we don't know how to prevent or treat early on. There will be a need for care for persons with advanced CVRD in low and middle income countries. And I think our volume rather uniquely acknowledges that there needs to be a strategy in most, at least middle-income countries, maybe in some low middle-income countries as well, to tackle diseases in their advanced stages. And the challenge is not only in acquiring trained personnel and technologies, for example, for dialysis delivery, but also in ensuring that there is financial sustainability on parts of the government and on parts of the patient. Because even if we make dialysis therapy available, for example, we have to offer it to people who can use it without having catastrophic health expenditure, as Nisreen first discussed. And that's a major challenge because it's such a large swath of people that need those kinds of therapies that the governments may not have the budgets to sustain everyone. At the same time, the people who are willing to take it on may not understand the full financial implications of using advanced therapy on the health and wealth of their households. And so we advocate for conscious strategies that take into account these financial implications before offering care for advanced CVRD in low and middle income countries.
The volume has put together an essential package of policies and interventions for prevention and management of CVRDs in these contexts. These interventions have been deemed both effective and cost-effective in low and middle income countries, though implementation feasibility may differ across countries. So the volume puts out that there needs to be a customized approach per country. What are a few of these interventions in this package, and how effective and cost-effective are they?
Right. So we put together a core intervention package, and those are highly effective and cost-effective. Let me lay out the interventions first. These are tobacco control policies, such as high excise taxation, fiscal or regulatory action to reduce salt in manufactured food products, bans on trans fatty acids, again, in processed foods to the extent feasible. And then we also advocate for opportunistic screening in high-risk populations for diabetes and in adults coming to primary care centers for hypertension. We further, in those scenarios, when we've screened a patient, we advocate for use of combination or generic therapy to treat these conditions. And we also highlight the need for use of aspirin beta blockers, ACE inhibitors, and statins. So this is a cocktail of drugs that can be applied across many conditions, many cardiovascular conditions. And we say that these should be made available to treat patients with heart disease, heart failure, and peripheral vascular disease, kidney disease as applicable, to reduce the risk of further application of complications.
So this volume covers cardiovascular disease, respiratory diseases, and diabetes. However, a bunch of the research has been done on cardiovascular diseases. What are other interventions, and how are the other ones relevant in this volume with regard to respiratory diseases and diabetes? What's getting done with those, and what are they like, in the low-income countries that might be different than the high-income countries?
Right. I mean, you're right, Jessica, in that the research on tackling chronic diseases as a whole has focused a lot more on cardiovascular disease than on some of the co-related diseases like diabetes, kidney disease, or even respiratory disease. And in our volume, we sift through the limited evidence that is available for tackling diabetes and kidney disease and respiratory disease. And we make a few recommendations. One is that we found that that self-management education for diabetes is highly cost-effective, and also screening for the long-term complications of diabetes, particularly with, for example, consistent foot care or screening for albumin leak in the urine to screen for kidney disease, are also effective and cost-effective interventions we found. In terms of caring for kidney disease, the data were very limited, but we felt that treatment of patients who have kidney disease and hypertension with use of a particular class of medications would be very, very helpful. And in areas where like in middle income countries like Brazil or India or South Africa that have a well-developed kidney transplant program, adding in deceased donor programs would be cost-effective as well. In terms of respiratory disease, we focused mostly on obstructive lung disease and asthma, and really recommended that first-level hospitals develop algorithms to care for patients with acute exacerbations of these conditions, sort of in the vein that that algorithms have been developed to manage acute heart attacks, and that some basic medications like low-dose inhaled corticosteroids and bronchodilators be made available for patients with these diseases at the primary health center.
Well, let's talk about costs of implementing this package. Are the costs reasonable for low and middle income countries, and how could low and middle income countries begin to implement this package?
So the volume provides two sets of cost estimates. One for the cost of each intervention in this essential package, and another that is an estimate of the cost of the whole package. And this package of essential intervention consists of 36 elements. It's actually quite wide-ranging and quite detailed. So Shushi's mentioned a few of these. And they range from interventions at the fiscal and public health level, so the population level, to intervention at the primary care level, to interventions at the level of specialized care. So the estimates show that on average, it would cost a lower middle income country about 1.5% of its GDP to implement the essential package and scale coverage rates up to the level that we know in upper middle income countries. So expressed differently, this comprehensive program of 36 different policy interventions could be achieved by increasing government health expenditures by 92% in low middle income countries. This is reasonable. Given the breadth of the package and the scale of benefit it affords, it's not unreasonable as a scale up. Now, the costs are much higher in relative terms in lower income countries. However, there's considerable variability in the cost of each of these single interventions in the package. So this means that many programs in the essential package are affordable, even in lower income settings. And a more feasible strategy for these contexts would be implementing a suite of interventions that we know to be more affordable or more cost effective, at least in an initial stage.
In addition to saying that governments could choose the more affordable interventions, we also say that they could choose interventions for diseases for which their burden is highest. So, for example, rheumatic heart disease is not something that every region of low and middle income countries is necessarily tackling, but people in Africa and India are still dying from rheumatic heart disease, and that might be something that those countries need to prioritize. In Mesoamerica, since this is my specialty, in Mesoamerica and Sri Lanka, there is an epidemic of kidney disease. And so even though some of the kidney disease interventions may be less affordable, because of this epidemic, those countries may want to choose to prioritize those interventions as well.
Nisreen, could you give us a little more detail about the costs and in terms of scaling it, particularly comparing between what it would take to do in low income settings versus the high income settings?
Okay, so let's try to put this in sort of monetary terms. So what we're talking about here is an essential package that would cost around, on average, $22 per person in a lower income setting. And that represents about 4% of current gross national income per capita of these countries. So something that's equivalent, again, it is very conceptually speaking, to a country experiencing 4% growth in income would be enough to cover the cost of this package in a lower income setting where actually these costs are a little bit more steep. In a lower middle income country, The costs per capita are $39 per person for the whole package, which represents a smaller fraction of GNI. We're talking about 2.1% of gross national income per capita in that setting. In terms of government spending would have to be scaled up again by about 190%, almost, for lower income settings, government spending on healthcare, in order to, again, afford all of these programs. And as I said before, about 134% increase for lower middle incomes.
Well, what about the value of implementing this package with regards to lives saved and costs in cases averted versus saved and saved costs? Because we talked a lot about the money, but really what matters is how many the health of the people that we're trying to better.
It's hard to attach a number or a price tag to the overall benefits from the package. For the estimation exercise that is conducted in the volume, the package is conceived as I said, a set of policies that would basically reproduce in lower and middle income countries the coverage rates that we currently experience in upper middle income countries. So the benefits, the size of the benefits really depends on the starting point of the country compared to this goal that we're setting.
We did not cost the package in terms of lives saved, but we felt that since the CVRD, the conditions covered in this package are actually the major cause of death in low and middle income countries, and doing something about them is on the agenda for most countries, even countries in sub-Saharan Africa, that presenting some options to these countries is what we needed to do, because regardless of the total number of lives saved, if we can provide affordable interventions that we know are highly effective and sort of pick them out for policymakers, that would make a large difference in the burden of CVRD.
Beyond the specific interventions, what high-level changes within low and middle income country health systems would facilitate implementation of this package and improve managing the growing burden of CVRDs in low and middle income country settings?
Yeah, I mean, that's a really key point, that there needs to be some sort of a high-level commitment to tackle CVRDs and then a conscious strategy for how to go about it. And because the evidence on what to do and how to do it keeps changing, we advise that governments consider something called a health technology assessment division or task force that continually considers the best evidence that's available and adopts it to the context of that country. For example, the UK has this in the form of the NICE, the NICE. Thailand has built a very nice and very effective health technology arm as well, health technology assessment division as well.
So many of the interventions that are included in this package require coordination across different arms of government. So for instance, the Ministry of Health and the tax authorities in the Ministry of Finance, which sometimes is uncommon in low and middle income countries. And so similar to what Shuchi was just saying about setting up a technology unit, a health technology unit, this kind of coordination requires a prior decision and a commitment. Similarly, there's a change in culture for many of these lower middle income countries from treatment to prevention. So screening for diabetes and hypertension, very similar to the fiscal policies that we're advocating for tobacco control and salt consumption reduction, they play a preventative role. So one constructive transformation in health systems in low and middle income countries would be to focus more on prevention and primary care and less on tertiary and specialized care.
Now, Shuchi, I know one of the other main messages that come out in this volume has to do with in terms of like really preparing to how we would implement the package and what the budget would require in different countries to do this, and how this would also kind of get integrated into universal healthcare, which is a huge topic that people are talking about around in global health a lot. Could you tell us a little more about this?
Right. So what we talk about is especially when this goes back to our point about advanced conditions and caring for people with advanced conditions. So especially when countries incorporate moderately advanced technologies into their universal healthcare package, and they need to be cognizant that budgets may need to accommodate an increase in demand. For example, in our recommendations for tackling respiratory conditions, we talk about that countries could, at tertiary level settings, offer people with advanced chronic obstructive pulmonary disease or asthma support with ventilation when they have an acute exacerbation of that condition. And that means that where many people are never making it to that center at this point and are not getting that support, if more of them are able to get that support, then the numbers of people who would benefit and who would want that treatment would increase over time in the countries, and budget planning would need to take that into account. So the current numbers of people are not a sufficient estimate, because obviously a lot of them can't afford that treatment and therefore are not getting it. But if countries make a conscious strategy to offer ventilatory support to people with advanced lung disease, then they need to understand that more people with advanced lung disease then will come to the tertiary centers and request that treatment.
You know, what you're saying about the fact that there's going to be increased demand, and we really need to kind of be thinking about that and how that affects our numbers and the estimates that we're making today is important, because people are living longer, especially around the world, and these conditions and diseases there is going to be an increased demand, and especially as we start building the capacity to treat them. So I appreciate that point. I think it's a good way it's a great way to end this and remember that. And I just want to say to our guests, Nisreen and Shuchi, thank you for chatting with us today. To our audience members,
Jessica.
Thanks for tuning in. Let us know what you think about this issue by commenting on the video or tweeting at us. We hope that you enjoy this episode, and you can check out more of our videos by subscribing to our YouTube channel, which all of these videos are also on our webpage at TWiGH.org, and you can find out more about us there. You can also find us on LinkedIn, Twitter, Facebook, Instagram, and we have a blog. And for those of you that prefer to listen rather than watch, you're in luck, because we have a purely audio podcast as well. And you can check us out there, find us on iTunes. So that's it for today. Again, thank you, Nisreen and Shuchi, and we'll see you next time. Bye-bye.